In this case of a diffuse interstitial lung disease, the first thing I'm going to do, as always in HRCT cases, is to look at the distribution of abnormality. We know that certain diseases like the upper zones, other diseases like the lower zones, some disorders have a peripheral distribution, whereas others tend to be more central or bronchocentric. Others are more random. Now, I think we can agree in this case, as I scroll up and down, that this is a mid/lower zone predominant disease. Once we've established that, the next thing to do is to determine which is the predominant pattern or patterns. There may be combinations of patterns. Now here, I think we certainly have increases in lung density, which are not obscuring the bronchial and vascular markings, and that is ground glass opacification. But within the ground glass opacification, there are interlocking lines, reticulations. We have a reticular pattern admixed with ground glass opacification. When I see extensive ground glass opacification, the next thing I do is to look at the airways. Is there evidence of airway dilatation or non-tapering, a sign of so-called traction bronchiectasis or bronchiolectasis? And this is a crucial sign of fibrosis. So whatever else is going on, we know if there is traction bronchiectasis, that there is fibrosis. Is there honeycombing? Well, honeycombing, the most reliable way to determine whether there is honeycombing is to look in the subpleural lung. And here in this patient, there is really not a hint of honeycombing. Now, admittedly, if you look at the upper zones, there is some honeycombing. There is microcystic honeycombing, but it is not a dominant feature of this case. Another sign that I want to point out is the volume loss. Now, how do we tell volume loss on a CT scan? Well, then we have to rely on the fissures or the major fissure. You can see the major fissure here is pulled back in relation to the front of the hemidiaphragm. This is where a normal fissure should make contact with the hemidiaphragm. The fact that it is pulled back tells us that there is significant lower lobe volume loss. So we have a fibrotic lung disease with a predominance of ground glass opacification, admixed with reticulation, and clear signs of traction bronchiectasis and bronchiolectasis. This is the pattern of fibrotic, non-specific interstitial pneumonia or fibrotic NSIP.